There we go. So I hope everybody can see that okay. Again, I really am grateful for the chance to speak to this group. It sounds like I really missed something special with the dance party the other night. It's been a while for me. I haven't had a lot to dance about, it seems like, and so that sounds like something that really was pretty tremendous. And I'm sad that I missed that. But hopefully, this will be the first of a long series of collaborations between Marcus Autism Center and some of the programs that I oversee there and LGS Foundation. So I'm going to be talking today, as Tracy said, specifically about behavioral interventions for problem behavior. And I know that there are lots of issues around LGS and seizures and behavior, and I've kind of heard loud and clear that how these things intermix and identifying what's contributing to what can be really challenging. And so I think that really speaks to the fact that any attempt to try to address some of these behaviors really needs to be multidisciplinary and incorporate the best information that can be gathered from all the different sources, all the different folks with expertise. But my focus today is really going to be mostly on the area where I have some expertise, and that's in challenging behaviors and behavioral approaches. So I will hopefully get to some of that other kind of how those things cross over as we go. As was mentioned, I'm at the Emory University School of Medicine. I'm an associate professor there, and they make sure that I always have to have a slide that shows all of these disclosures, quote unquote, which really shows that these are grants and research grants that I've been involved in. In essence, what this is saying is that nobody's giving me any money to say anything in particular, but I always like to say, hey, if you know someone who wants to give me some money to say something in particular, it's not that I'm necessarily, ethically upstanding. It's that just I don't have a lot of opportunity. But in all seriousness, I'm going to talk a little bit about understanding problem behavior as a place to start. And one of the things that I hear a lot as I talk to families of kids with all kinds of developmental conditions and challenging behaviors, I'll ask the question, like, what have you tried? What is in place currently from a behavioral approach standpoint? And really, when I say behavioral, these are more non-medical solutions or strategies, things like having certain consequences for problem behavior, teaching certain skills, things that one can do as a parent from a more behavioral standpoint to address these issues. And you consistently hear the same kind of thing from families. They'll say things like, well, we tried fill in the blank. We tried timeout for a little while, or we tried a token system, or we tried rewarding good behavior, or whatever, right? And they'll have a example of what they've done, and you ask them, did it work? And they'll say, well, kind of, sort of, for a while, but not consistently. And that seems to be a really common refrain that I hear over and over and over again. And maybe that applies to some of you, that you kind of say, yeah, we tried some stuff. It sort of worked. It sort of didn't. It worked for a while, and then it stopped working. And there are some really good reasons for that, because what's interesting is if you look at the research literature on these strategies, there's lots of evidence that they can work. But the question oftentimes becomes not one of, can this ever work under any circumstances, but how well will it work for me, and how long will it work, and how can I keep it working? And so there's some really good reasons why these strategies sometimes work and don't always work that are important to understand if one is to try to take full advantage of them. So first, I want to talk a little bit about how people conceptualize these problem behaviors and think about them, because what I'm hopeful today more than anything else is that I can shift your thinking just a little bit to thinking about these behaviors in a different way. And my hope is that by doing so, that will maybe give you some new insights that might be helpful in you as you take care of loved ones with LGS. So when we talk about problem behavior, there's lots of different ways to try to categorize problem behavior. Probably the most common, people don't necessarily use this term, topography, but topography is probably the way that most people talk about problem behavior. And really what that just means is, what does the behavior look like? What's the form of the behavior? So there's lots of different topographies of problem behavior. Just to use an example, aggression is one topography of problem behavior, and there's even lots of sub-topographies of aggression. Things like biting versus headbutting versus throwing things at people. These are all just different forms of aggression, all of which are different topographies. Now, why is this important? Well, oftentimes folks will talk about topography and kind of your lay people or people who aren't trained behaviorally as much might think about, what do we need to do about this kind of behavior? How would we deal with aggression or self-injury or tantrums or what have you? Again, kind of from that topographical framework. And so folks tend to think about, well, for behavior X, I should do strategy Y, that these two things are linked. And we call that a topographically prescribed treatment. I've had lots of examples of folks who, they'll tell me that, I went to a family reunion and I got lots of advice on how to parent my kid. That's true for everyone. For me too. I go to a family reunion and my kid throws a tantrum and somebody looks at me. First thing they say is, wait a minute, didn't you go to school for this for a really long time? Aren't you supposed to know how to handle this? There's that expression, the cobbler's children have no shoes, and then my kids act up as much as anyone else's, right? But the second thing is they always want to give you lots of advice. Oh, well, what you need to do is just X, Y, and Z, some really simple thing that, if it was just as simple as that, we all would have done it, right? But it's oftentimes based on what the behavior looks like. I live in the South, and when I moved to the South for the first time, I learned about a topographically prescribed strategy for toddlers who bite other kids, right, or who bite others. It was kind of unusual for me. I hadn't heard this before, but what is it you're supposed to do if a toddler bites? You're supposed to bite them back. Not really sure where that came from or why we think that biting kids is a good idea, but when I moved here, that was a thing. Maybe it's just not just the South. Maybe it's just when I had kids at that age range. But I heard that you're supposed to bite them back. Another one would be timeout. So if a child bites, put them in timeout. The biting is the thing that is driving the strategy or helping you select a specific strategy to use for that kid. So biting equals timeout, or hitting equals timeout, what have you, right? So I want to run through one quick example. This is a hypothetical example of a young man with LGS. I like hypothetical kids because I always do exactly what I want them to do, and it makes my point really clearly. But we'll just call this young man Tim. So let's say Tim is someone who screams, tantrums, maybe even hits his parents sometimes. And he does it in two different situations. Sometimes he screams and hits when they make him turn off the TV. It's, hey, it's time to get ready for bed, time to turn off the TV. And so he might get aggressive or scream. Sometimes he hits when they tell him he has to do some self-care task, like brushing his teeth. So two different scenarios, but basically using hitting and screaming in both of those situations. So let's think about this from that topographically prescribed system approach, right? So problem behavior X equals treatment Y, screaming and hitting equals what have you, right? So let's say hitting equals timeout. That's the topography of the hitting. So topographically prescribed, timeout. Every time Tim hits, he should go to timeout. So now let's think about this from Tim's perspective. And this is, again, when I say I want you to think about these behaviors just a little bit differently, this is where that starts to come up, right? So thinking about it from the perspective of the individual and what is it that they might learn from those consequences and how that might shape up their behavior going forward. So again, topographically prescribed treatment, hitting equals timeout. Tim hits his parents in the first scenario. It's time to go to bed. He doesn't really love going to bed. They tell him turn off the TV. He gets aggressive. They send him to timeout, right? That's the strategy. Hitting equals timeout. So he's hit, therefore he goes to timeout. And so what is Tim thinking when he hears this, right? He maybe doesn't vocalize this, but thinking about it from his standpoint or his perspective, well, when I hit, not only do I get to not watch television, I don't get to do anything. I kind of have to sit in this timeout spot. That kind of sucks. Over time, you would expect him to start to learn, all right, hitting, not only is it not getting me more access to television, my world gets worse instead of better. And so over time, you would expect him to start learning that hitting really isn't going to be very productive for him under those circumstances. Okay, so that's not a bad outcome. Now let's think about that in that other situation. So it's time to do some self-care task, put on his shoes, brush his teeth. Parents say, hey, it's time to brush your teeth. Well, Tim doesn't like brushing his teeth, so he screams and he hits, and so he gets sent back to timeout again. Well, thinking about it from Tim's standpoint, what is he learning in that situation? What would his perspective tend to be? Well, when I hit, I don't have to brush my teeth. In fact, I get to go over here where there's no toothbrush and none of that stuff that I don't like. During these COVID times, I'm spending a lot more time at home and with my family. And, the other day this came up and I said, could I please get sent to timeout? Would someone please say, I would love some timeout right now. A little solitude would not be the worst thing in my world. And so you see this again. And I actually saw a greeting card a while back that said, all my childhood punishments are now my favorite things. Getting sent to timeout, having to take a nap. These are the things that all of us tend to like more and more as we get a little bit older in life. But in this example of Tim, the topography, the hitting, the topographically prescribed treatment, he goes to timeout. This is not going to work. In fact, it's probably going to make things worse. The next time Tim has to brush his teeth, he's like, oh, remember that time when I got upset and I screamed and I threw the toothbrush and I hit somebody? Man, I didn't have to brush my teeth that time. That's the way to go. So again, not that he's necessarily going to verbalize that, but thinking about it from his perspective, we see that this is not going to be very effective. And I think this oftentimes leads to why I hear from families, well, sometimes it works, but sometimes it doesn't, and it worked for a little while, but it was inconsistent. And that's because these treatments, if they're based on the topography of the behavior, are not really going to fit every situation. And as a result, you see this kind of hit and miss mentality or hit and miss result in terms of how these strategies can tend to be effective or not. So I want to talk about an alternative approach now, and I think you're kind of starting to see hopefully where I'm going with this, and that rather than talking just about the topography of the behavior, starting to think about it in terms of its function. Function in this case just means the purpose that the behavior serves for that individual specifically, right? So what is it that that person is getting or getting out of by a result of their behavior? And even if it's not every time, it can be intermittent, that sometimes it has a payoff and sometimes it doesn't, but it's what might be happening that's keeping that behavior going. And that leads to this different approach we call a function-based approach, in which we define the behavior not by what it looks like, but what purpose it serves for the individual. So thinking back to Tim and that example I gave before, there's really two functions going on in those two different scenarios. One is to maintain access to a preferred thing in the form of the television. The other is more of an escape behavior, to get out of doing something he doesn't like, to get out of brushing his teeth, or those other self-care types of tasks. So two different functions, and we actually have to think about those as perhaps needing two totally different strategies, almost as if they're totally different behaviors. Even though in both cases it's hitting and screaming, thinking about those as two totally different behaviors that serve two totally different purposes for Tim is really the key. So in the example of Tim that we had before, again, thinking these two things through, you see at the top here, we have two different strategies. Hitting that's occurring to access preferred activities. Yeah, go ahead, timeout. Timeout's going to be effective in that scenario. We talked about why, right? Not only do I not get television, I don't get anything, timeout's going to work over eventually. And then that other situation where it's more of an escape behavior to make people back off or to get out of something that he doesn't like, you would have a different strategy altogether, which might be to follow through even with the toothbrushing or whatever that task is. So ask him once if he doesn't do it appropriately, or if he starts to engage in behavior, you can escalate to doing hand over hand, or basically following through with the task, whatever it is, so that there's no opportunity to escape or avoid. So again, thinking about this from Tim's perspective, we talked about the first one, right? Timeout's going to work. But in the second situation, when there's that level of follow through, hey, when I hit and scream, I still have to brush my teeth. I might have to do it a little bit faster, and I have to do it mom's way instead of my way. That may actually be effective over time. So again, this intervention, this approach is really having to be tailored to the function of the behavior. And in fact, thinking about these behaviors completely separately, even when they serve the same function, even when they have the same topography, if they serve different functions, thinking about them as entirely different behaviors because they serve a different purpose for them. Now, I want to talk about what functions of behavior exist, how they can actually be divided up, because there's lots of different types of behaviors that serve different kinds of functions. And again, you can have the same behavior serving different functions. You can have lots of different behaviors all serving the same function. So a kid who hits and screams and hits his head and throws items all to get access to preferred items, those would all be the same class of behaviors because they all serve the same purpose for that kid, for that individual. And two really broad categories of functions are what we call social behaviors and more automatic behaviors. Social behaviors are those behaviors that, and it sounds like socialization, and certainly behaviors that occur to get attention is one example of a social behavior, but really a social behavior is any behavior in which the consequence is mediated by another person. This just means that in the chain of events that take place between the behavior occurring and the eventual outcome, someone else is involved in the middle there, right? So like a cookie can be a social behavior if screaming and tantruming results in a cookie because mom was in the middle. Like I screamed, mom went, got it off the top shelf and brought me a cookie to calm me down. That's a social behavior. Even though it's a cookie, we don't think of cookies as social per se. It's the fact that there's someone else intervening in between the behavior and the consequence that is what makes it social. So going back to Tim, right? Turning on and off the television. Mom giveth and mom taketh away television and screens, right? So that makes those social behaviors. Mom presents the demand to brush teeth. Mom can back off if she chooses to. Again, wouldn't recommend it, but that would be an example of a social behavior because mom can present demands, mom can remove demands. It's sometimes easiest to think about social behaviors in contrast with the alternative, which is these automatic behaviors that just automatically produce the consequence that maintains them. A lot of the time, these behaviors are behaviors that we think of as stimulatory in nature. They don't necessarily have to be. There's other examples of behaviors that are automatic that don't have that automatically stimulating consequence, but that's a lot of the time what we're talking about. So behaviors that occur where the behavior, just as the name would suggest, automatically produce the consequence. We had a young man who would poke at his eye, and he'd actually had to have his eye reinserted, which was not a thing that I knew you could do. But he would poke at his eye, and we showed that over time. We figured out that the purpose of the behavior was because if you poke on your eyeball, you can cause the photoreceptors in the retina to fire and cause kind of flashing lights. You see flashing lights just by putting pressure on your eye instead of light hitting those photoreceptors like they're supposed to. And so he saw kind of flashing lights. So the behavior, poking, automatically produced flashing lights, which was kind of the coolest thing in his world. For some reason, he really was into that, liked that a lot. That was the thing that really was motivating to him. And so that would be an example of an automatically maintained behavior because there's no one else involved. Poking your eye automatically produces the flashing light. It's not like you poke your eye and mom makes the light occur. It's automatic. So there's that distinction between social and automatic. And the reason that I think automatic is particularly important to understand is that these are behaviors that can be a little bit more different, can require different types of treatment, and in some cases are more difficult to treat for reasons that I'm going to get to in just a little while. Again, these are oftentimes seen as stimulatory, some stereotypic behaviors, some types of self-injury like head banging can be automatically maintained. Sometimes they have to do with some underlying medical issue, right? Kids who have dental pain, for example, and you see them kind of pushing, or kids who get headaches and they poke at their eye because it's one of those ocular headaches. We've all had them where it feels like, the pressure in your eyeball. So they'll poke at their eye or they'll bang their head. These are behaviors that can be automatically maintained. Certainly there can be increased irritability due to things like seizures, for example. And I know that that's such a big deal in the LGS population. There's questions about whether or not seizures just directly produce problem behavior, or is it more that they increase irritability because you feel funny and uncomfortable, or it causes pain, and then as a result of that, anything that goes on around you. So maybe a lot of the time you're fine with mom asking you to brush your teeth, but you just experienced a seizure and now she's telling you to brush your teeth, and so you're at a heightened state. So that thing that normally wouldn't bug you quite so much now is causing a problem behavior to occur when it wouldn't have before. And so we would think about those as still social behaviors, but social behaviors that are related to irritability due to a medical condition. And so again, for these types of behaviors, especially the automatic ones, it's always really important to do everything one can in order to address any underlying medical issues before attempting these behavioral strategies, because behavioral strategies on their own may not be effective if there's something else going on. Doesn't mean that they're not. And I've seen lots of kids with lots of seizure conditions in the past. And so, yeah, it makes things more tricky. It makes them difficult, but the behavioral strategies can still be effective. It's just a matter of working together with physicians to understand what's going on medically and try to address those things together. So when it comes to, all right, great, let's say maybe I've convinced one or two of you about this importance of function. Well, how do I figure out the function of my kid's behavior, or the person that I'm taking care of? And so part of that is that there's a lot of different approaches. These are sometimes called functional assessments. And there's one type of functional assessment that is kind of considered the gold standard or the benchmark that that the rest are measured against. And this is functional analysis. And a functional analysis really is kind of like I think of it as the behavioral allergy test. If any of you have ever had allergy tests, and they prick your skin with like 50 different things and they look for where there's a reaction. This is somewhat similar to that in that it sets up these what are called analog conditions. So situations that are similar to situations that occur in the real world, but in the real world, there's just too many things going on. And so it's really hard to isolate that, just like with allergies, right? So you go out and you walk through a meadow somewhere and you just get massive hay fever and maybe you break out in a rash. And it's really hard to figure out which of the things you were around caused that allergy. The same thing can happen when you see problem behavior. I take my kid to the store and my kid has a tantrum and I'm like, really seriously? Like, we come to this store every week, but today we're having problems, and it's hard to figure out why today. Is it because we were walking through the store and we went past the candy aisle and that was a problem, or did we see some balloons, or did somebody make a face at him, or we had a person try to put a sticker on him? And my kid hates stickers, which is true. So like, this is just all these different things are going on, and it's hard to isolate what was the one thing that caused this particular episode of behavior. And so this functional analysis sets up these conditions one at a time in a way that lets us test out and observe reactions in a controlled situation. So this is just an example, and hopefully you can see my cursor on the screen. This is an example of data from a functional analysis, and really what these show is each one of these little points here is a different situation. So the squares represent one situation, the circles represent another, and so on. And basically, the higher up these are along this axis, the more problem behavior we saw. In this case, we were talking about aggression and disruptive behavior. So each one of these are 10 minutes. And these closed circles, these dark circles that look like this, basically, these are what we call a control situation. And so there's free access to preferred items. We've done some work in order to identify some preferred things. It also includes lots of attention, no demands. And so you would hope that in most situations, most kids are doing pretty well in that scenario. And that's actually what happens. If you look at all these dark circles, you can see they're all right along this x-axis, showing that no problem behavior occurred. So that's great. That's what we're trying to contrast with. Now, if you look at the closed off squares, the darkened squares, this is when there was restricted access to a preferred thing. Now, in this case, I remember this young man. This was a young man who really liked screens and iPads. So we would give him a little bit of time with an iPad, just like you might have in home or at school or wherever. And then a therapist came over and said, hey, you know what? Time to put that away. Again, it's something that happens every day probably. But in this case, when they restricted access to that iPad, we started to immediately see some problem behavior. You see it occurred, and then it went away. But as we did this across more and more sessions, we saw that the problem behavior was pretty reliably occurring, suggesting that for this young man, restricting access to an iPad is what's causing that problem behavior. And so we're seeing elevated rates of problem behavior in that scenario. Now, these triangles are just a little bit different. These are situations where they're presenting demand. So you'd have, again, some alone time, and then someone come over and say it's time to do some work. In one case, the closed triangles, I believe, were academic tasks. The open triangles were more self-help skills or tasks. And again, in both cases, anytime they presented it with time to do some work, we started to see problem behavior, and then they would back off, just like a teacher might do or a parent might do. Hey, never mind, you don't have to do the task. And then after a few seconds, go back to trying to get them to work again. And so you can see that from these data, we concluded that we consistently saw problem behavior in situations where items were being restricted, as well as when demands were being presented. But we weren't seeing problem behavior in a control, suggesting this wasn't just random, that as long as he had things going his way, he was all right. And in fact, in these open squares, you see no problem behavior either. And this was a scenario when someone would restrict their attention. And so doesn't seem to be occurring when he's not getting attention, doesn't seem to be occurring as long as he has his preferred things and no demands. But you start giving him work to do, or you start taking away the screens, that's when we started to see problem behavior. And that tells us what his function is. Again, this is pretty much considered a gold standard, but it's tough. It's not something that you can do at home in every situation, and it's not something that you can do without some good training. But there are some things that you can just do on your own. And really, probably the number one thing is to just ask some questions. Not every kid needs this level of functional analysis to identify the function. Sometimes it's pretty obvious. Questions like, does this behavior consistently occur in certain situations, times, or places? I hear, the behavior always occurs when the kid's at school in the lunchroom. All right, well, what's going on in the lunchroom? Is there something about lunch or the cafeteria that's particularly tough or that's causing some problems? What would happen if, and then fill in the blank, what would happen in those same situations that I described from the functional analysis? What would happen if you didn't give them attention for 5 minutes? Well, when I've seen a parent where they say, yeah, that would absolutely cause a tantrum. What would happen if we took away a screen? Wait a minute, you're not going to do that, are you? That's what I typically hear. Don't take that away because that will absolutely cause problems. What happens if you presented a demand? Another one is that we tend to think about these behaviors as a form of communication for most of the individuals that we work with, because many of them are limited in terms of their ability to communicate effectively. And so this is just a way of saying, hey, look, you know what? I'd prefer it if we could keep watching TV for now. Or, you know what? I really don't feel like brushing my teeth right now. Now, there's nothing necessarily wrong with saying that. It's that they're using problem behavior to communicate. And so, again, oftentimes just thinking about what are they trying to say tells us a lot about the function. What are some times and situations when the behavior never occurs? This is kind of like that control condition. Well, he's always fine as long as he's got his screens. We had a young man recently who had to have 11 screens with him at all times, 8 iPads and 3 cell phones. And really, parents couldn't charge anything until he was asleep, because if they tried to remove any of them, he started to engage in a lot of problem behavior. And so these kind of things, well, as long as he's got his screens, he's fine. That tells us, well, the problem behavior might be related to screens. And so we might have to do something about that. And then the other one is, most families are pretty good when I just ask the question, hey, if I really wanted to cause problem behavior, what would I need to do? Oh, for sure. Turn off the Xbox, or go ahead and take this preferred toy. Take away Buzz Lightyear. That'll cause it for sure. I don't know if kids play with Buzz Lightyear anymore, but that used to be the thing, right? And so any of those types of things if the caregiver can oftentimes be very good at telling exactly what would cause problem behavior, because they spend their whole day trying to avoid that thing from happening. All right, so I want to get into, now that you've identified the function, hopefully, or you've gotten help from someone to help identify the function, what does one need to do about that? And I'm going to talk a little bit about interventions. Now, again, this is oftentimes something that requires a multidisciplinary team approach, including your medical professionals and psychologists or behavioral folks to identify some strategies. But regardless, one of the things that I have found is really important is to keep in mind that from a behavioral strategy standpoint, there really need to be 4 ingredients for every good strategy or set of strategies. The first of these is focusing on prevention. And prevention is exactly what it sounds like. It's the stuff you do to avoid the behavior from occurring in the first place. And there's certainly a time and a place when this is important. I'll talk in a minute about how over-reliance on preventative strategies can actually be detrimental. But in general, it's an important tool to have in the toolbox. There's things that one can do just to make life easier to get through, and prevention is oftentimes a big part of that. The second would be behavioral interventions. This is really a term I use to describe those strategies that over time are going to reduce the behavior from occurring in the first place, right? So these would be the behavior occurs, how are you going to react to it so that it's less likely to occur the next time around? The stuff we were talking about with Tim earlier, right? That there's time out or there's following through on tasks. These would be examples of behavioral interventions as ways to, over time, see reductions in the behavior so it doesn't occur in that same scenario in the future. Now, another thing that is sometimes overlooked is what I call behavior management approaches. And so behavior management is, again, just the term that I use to acknowledge that these types of strategies, and including medical strategies as well as behavioral strategies, oftentimes are very, very helpful, but they rarely completely eliminate the behavior altogether. We had a young man who, when we first started seeing him, he would hit himself in the head. He hit himself in the head. I have the data, I have the chart to show it. He hit himself on his first day in our service 1,600 times in a 6-hour day. Now, we were able to achieve a pretty massive reduction in his problem behavior. We saw, I think, a 95% improvement that we were able to achieve. So 95% improvement is great. That's a big improvement. But if you think about what that means, that's still hitting himself in the head 80 times a day. You shouldn't hit yourself in the head 80 times a day. Even if you used to hit yourself in the head 1,600 times, 80 is still too many. And so there has to be this recognition that these strategies oftentimes are very, very helpful when done correctly, but still leave a little bit on the table in terms of some behavior that may occur in certain situations. Or sometimes you have to have strategies in place while you're putting the behavioral intervention together so that while you're working on that, when the behavior does occur, what are you going to do to minimize the impact of the behavior or the effect of the behavior? So we're maybe working on a strategy with that young man. We haven't gotten to 95%. What do we do when he goes home so that mom's not dealing with the other 1,600 behaviors that occur, the other 6 hours that he's awake, that he's not in our center, so he's safe? What do we do to make sure that we can work on IEP goals with him so that when he's in school, he's still making progress? So there's a lot of things that sometimes have to be done to just address the behavior that is occurring, acknowledging that you can't necessarily eliminate everything. And then the last piece is crisis management. It's important that we acknowledge that these behaviors sometimes come out of nowhere and you're just not really prepared for it. And you got to do whatever you need to do to stay safe. So again, I'll talk about each of these in a little more detail. Unfortunately, there's limited time, and I know there's some other really amazing speakers today, and so I'm not able to get into a ton of depth about some of these things, and I'm sorry about that. I mean, I have an actual workshop series that I do, which is 6 hours a day for 5 days covering this, and even then it feels like we're just scratching the surface, so this feels like just a drop in the bucket, I'm sure, and I'm sorry about that, but I will just cover a few points really quickly to hopefully just highlight some of the more important issues that can come up. So I mentioned before prevention, and prevention is really great. A lot of families are pretty good at identifying ways to prevent the behavior on their own. I had a young woman where she really loved slushies, and every time the family drove past her favorite convenience store, she would flip out and get aggressive. And so they actually had they had the means to do it. So they went and bought a slushie machine and kept it in their house. I always felt like, well, good for you, I guess, if you got slushies on tap whenever you want. But what happens when the slushie machine breaks, right? There's another young woman who we had worked with who she would get really aggressive anytime she'd be listening to preferred music and it was turned off or the music changed. She really loved gospel music. And so Dad would work with her, and we had a lot of strategies that we were working on, but also, she would get aggressive if they were driving in the car and the music changed. And so she attacked him from behind in the back seat one time while they were driving on the freeway. I live in Atlanta where we have Highway 85, which I know it's called Highway 85, but in part because that's the minimum speed, it seems sometimes. And so she had to pull over. She actually got out of the car and was able to run out into traffic with 85-mile-an-hour cars. And fortunately, nobody was hurt. But that's one of those times when behavioral interventions are all to the good, but you just come up with a playlist and put it on loop and keep the gospel music going nonstop, right? Prevention is really important during those times when the behavior is just intolerable, like when you're driving on the freeway. So those are really important strategies that are good to have, but there can also be a tendency in some cases to overly rely on those prevention strategies. Again, these are terms that you won't find in the literature anywhere. They're just terms that I've kind of adopted. But really, one approach would be accommodation and another would be more integration. And so if I were to kind of think about two different families, maybe of that young woman with the slushies, and think about how they might approach challenging behavior, a family who's taking a more accommodation approach might think, well, my daughter, she's got some developmental differences. We want her to be happy. She loves slushies. We can afford to put a slushie machine in the home. And so let's do that. Let's try to keep her as happy as we can because we want our child to be happy, just like everybody else does. And there's nothing necessarily wrong with that. Whereas another family who might take a different approach would say, well, yeah, our daughter has some developmental differences. She really likes slushies. The world doesn't generally have slushies everywhere. We want her to learn to kind of get around without having slushies all the time. And so we're going to work on getting her to tolerate not having slushies all the time. So one is more avoiding problem behavior. The other is more working through some problem behavior. In one instance, the accommodation situation, this child might be pretty happy a lot of the time. Who wouldn't be? Slushies all the time. That sounds great to me. I like a slushie as much as the next guy. Whereas in the other scenario, and in a more integrated strategy, the child's going to be pretty upset sometimes when they want slushies and they're not getting them, and you're working on, well, you can't have these all the time. And so both of these are reasonable points of view. People get to make decisions about what's right for their loved ones, and they're working with their loved ones in order to make their situation as successful as they possibly can. The big issue that I sometimes see, though, is when caregivers want the individual to be all happy all the time, but they also want them to learn all of the skills that they can and to tolerate periods of non-access or whatever, right? It's almost this mismatch that you want that outcome, but you want to do this thing. You never want to work through anything tough, but you want your loved one to learn all the skills and be able to adapt and be as integrated as possible. And so there are these two things they do that mismatch can create conflict. And so really it's a recognition that if you're going to want that outcome, you're going to have to do some of the bits and pieces to get there. And that's where challenges do occur. And that means being willing to work through some things and really deal with behavior from time to time, even if there might be ways to prevent it. One of the big ways to do this is to really identify that sometimes you have to take a step backwards in order to take a couple of steps forward. This is really getting into behavioral interventions in particular. And it's this idea that sometimes we may have made some gains and we're kind of getting by pretty well, but in order to address challenging behavior, we have to take a couple steps back and get things under really good control before moving ahead. I think about a young man that we worked with where we went to his school, and the school was asking for assistance. The teacher wasn't necessarily asking for assistance, but the school psychologist asked us to come in. We went in, and this young man, he was running around the room, and he was throwing things every which way, and he would grab people's papers off their desk and rip them apart and throw them and screaming as like Tasmanian devil, right? And we asked the teacher, what's he supposed to be doing right now? And so he's supposed to be sitting at his desk doing seat work on worksheets for 15 minutes. And we said, okay, well, we'll get started on that. And we had to take some big steps backward. Just telling him sit down and stay there and holding him in his chair is not going to work very effectively. So we had to take a bunch of steps backward and really just tell him sit at the desk, right? As long as his butt hits the chair, he got a preferred thing. As long as he was staying in his seat, he got access to, I think it was a screen or something like that he really liked. And then if he just did that for a couple of seconds, he could get it, and then he could get out of his seat again. And then we started to gradually increase the amount of time. He had to sit in the seat for 10 whole seconds, and then he could get the screen. And then it was 15, and then it was 30, and then it was a minute, and so on. Then we started to kind of swap out the iPad for a worksheet. And if he did if he just made a mark on the worksheet without tearing it up, he got the screen back. And then we kind of gradually started getting more and more work, got to a point where he was able to sit for 10 whole minutes, sit and work at the desk for 10 minutes. And we went and looked at the teacher, look, this is great. He's sitting at his desk for 10 minutes. And she said, well, it's supposed to be there for 15. And she was really dissatisfied with what we had done. And part of me feels like, well, we'll get to 15, but this is a lot of progress. It's also 10 good minutes instead of 15 minutes tearing apart the place. And so sometimes this unwillingness to take a step back is really, can be really challenging, because it can be so important to say, look, let's acknowledge that things aren't going great. We're going to have to take a step back and get things under control before we move ahead. There are a lot of ways in which one goes about doing that. And so getting into these behavioral interventions, one of the big pieces is what we would refer to as extinction. That's just disrupting the relationship between the problem behavior and that functional consequence. So if the behavior is occurring to get access to an iPad, making sure that when the problem behavior occurs, the iPad never is a result of that, that would be an example of extinction. And that can be really effective, but it's always going to be more effective if there's still some alternative way to get access to the same thing. So if the behavior is, like we said, kind of a communicative type of behavior, then in that case, it's teaching some other way to access that preferred thing. And then going ahead and moving, and sometimes people say, well, that's all well and good, but just teaching the kid to request the iPad, he's still getting the iPad all the time. That's not what we're trying to do. He's got to work on tasks, and you've got to have meals, and we're trying to get through the day. And if he's got an iPad all the time, we can't necessarily do that. So that would be this third phase of increasing social validity. I want to show you an example of some data from a kid that we worked with. This is actually the same kid that I showed the functional analysis for, you remember? So there were kind of those two functions, access to preferred items. It was an iPad for that kid. I'm using iPads as an example a lot. We've actually got some data to show that seems to be more and more common. It doesn't have to be that, though. It can be snacks. It can be lots of different things. But for this young man, it was an iPad. And so he would get aggressive, as we said, whenever people restricted that. And these are some baseline data here. You can see, we're getting at least 5 instances on average of behavior every 10 minutes, or sorry, 5 per minute instances of aggressive behavior when we were restricting that iPad. So that's a lot of aggression, right? Over 10 minutes, you're getting 50 instances of aggressive behavior. And so that was relatively stable. So we did the functional analysis, and then we did something we call FCT, in this case, functional communication training. In essence, we just taught him an alternative way to access the iPad. Instead of hitting people and becoming aggressive, we actually taught him to request it appropriately. Now, he didn't have any vocal speech, so we actually taught him to hand over a card that he could hand to someone that says, iPad, please. And if he handed them the card, some of you have heard of PECs. This is a little bit like PECs. If he handed over the card, they would give him the iPad. He could keep that for 30 seconds, and then they'd remove it, and he could hand the card right back over and get the iPad again. And you can see when we did that functional communication training, there's a little bit of problem here, but pretty quickly it comes down and stays pretty low, which felt pretty great. We're like, hey, look, look what we did. We were able to get the problem behavior under control, but we're rarely just convinced by data like this. We usually want to make sure. And so we actually went back to baseline, and sure enough, problem behavior came back. And then when we reintroduced treatment, it got better again. So this told us that, this really is about the treatment. It isn't just that it was Tuesday and it's Taco Tuesday and he loves tacos, so he was good. No, it really was the treatment, because when we took away the treatment, things got worse, and when we put it back, things got better again. So this is all well and good. These are actually the data for communication. When we first started, he wasn't requesting things ever. And then when we started, the FCT this is how often he's handing over the card. So he's using it pretty reliably. So he's using communication instead of problem behavior, which is great. That's exactly what we're aiming for. But some of you probably, or if not all of you, spot the problem, which is great. Now he's just asking for the iPad all the time. He has the iPad all the time. That's not really solving my problem. And that's that social validity piece. That's taking these types of strategies and moving past just the early phase of replacing the problem behavior to now making it actually useful and usable, so that you have periods of tolerance. And so in his case, these are those same data. They're kind of just scrunched together, right? So here we have those problem behaviors, and then treatment worked really well, and it went away, and it came back. And what we did next was something that we called use a strategy of bringing the behavior under the control of different types of signals or symbols. In his case, there was a green card and a red card. Green for go, red for stop. And when the red card was out, it meant that if you ask for the iPad, if you hand over that card that says iPad, please, someone's going to say, not now, we can't have that right now. And it was just initially very, very short, like 15 seconds. If he handed over the card, not right now, but eventually the card would switch from red to green. And then if he handed it over, he could have the iPad. And so you can see, and so this is the same communication data. You can see that initially, for him, we started out at 80 seconds. So the red card would be out for 80 seconds. And if he handed it over, then he wouldn't get the iPad. But after 80 seconds went by, the card would switch to green, and then he would request again, and he could get the iPad. And so initially, he wasn't asking. We see that problem behavior kind of came back during those times when he was on red, and the requests started to work just kind of mixed. But over time, what we saw was eventually he stopped asking. That's where you're seeing that the requests are way down during these red periods. That's these open triangles. And problem behavior stayed low. And then we started to increase. We went from 80 seconds to 160 seconds and kept increasing. And we eventually, and even though the time that was green stayed relatively brief, like 30 seconds, eventually we got to a period where he could go 10 minutes or 15 minutes without requesting the iPad and still engage in no problem behavior. And so this was giving the caregiver some control and saying, like, you can't have the iPad all the time. Now, 15 minutes, I'll acknowledge, is not everything, right? 15 minutes is not going to get you through life that way, but it's a good proof of concept. It's this idea that now, once we're at 15 minutes, we think we can start to continue to increase and see a period of time where this was a family. I remember talking to them when they first started. Mom said, if I could just use the bathroom without him having to be with me, my teenage son, that would be great. And 15 minutes lets mom kind of do some chores, do some things around the house, maybe use the bathroom without her son being there, so that she can address some of those issues, and basically saying you can wait for a little while. You can go to the store and do 15 minutes on, and then a minute or two of iPad and back and forth, and then continue to gradually increase the time when the red card is out. So this is an example of how these interventions really need to move into this phase of making them more socially valid. Some really important things about these behavioral interventions: they do have to be implemented consistently. And that can be really, really tough. And this is something that takes time. It also requires a lot of adaptation. And so really one of the biggest things to do is to be proactive and practice these things carefully. We talk a lot about practice sessions being one way to do these things. And it's important to do these kind of practice sessions at times when you really are able to do them well, that you can do them with good integrity and with fidelity so that the situation is not necessarily chaotic and you're not able to implement the strategy effectively. So for example, planning ahead, being systematic, don't set yourself up so that if you put yourself out in the community, if this is something you're doing in public, you're not going to be embarrassed by leaving suddenly. You can control the situation, follow through. And it's also important to always end on a good note. One of the things I see a lot of times is that people will say, well, he's doing so well. Things are going really well. Let's do one more, right? I know we said we were only going to do this for 10 minutes and it's 9 minutes and 58 seconds, but it's going so well. And you push it and then it goes badly. And now you have to follow through because if you end, it's like, look, with this thing that we started practicing, we're going to end early because it's going badly now. The individual might learn like that's a good way to get these things to end. So other things, keeping realistic expectations, really identify those things that are going around that could cause problems. I want to give you an example really quickly. So one thing that I hear from families sometimes is going out to eat is a real challenge. I've heard families say, my wife and I haven't been on a date since our child was born. Well, how old is your kid? He's 14. Now that's really tough. And again, these are things that are probably not news to a lot of you, but that is something that can be really difficult. And it's not surprising that these kinds of behaviors put real strain on families and loved ones. And so an example of how setting up practice sessions going out to eat, we did this with my son. So I have a son who has some developmental challenges. And so early on, we decided this was a thing that we wanted to work on, so we weren't going to be so isolated, our ability to go out. And so what did we do? Well, one of the things we did was said, well, we're going to go to like a Mexican place or an Italian place at 4:00 in the afternoon when the place is nearly empty. Why? Because we don't want to be sitting waiting for a table, and we want to have food on the table as soon as we sit down so that we can practice working through going out to eat. We wanted to tell our server, here's our credit card. Have it ready to go so that if we have to leave suddenly, we're not trying to flag you down to get you to come over here. Like we might leave suddenly, let them know what we're doing so it's not a shock to them. Hey, we're working on this. And if this goes really well, we'd love to be patrons and come all the time. Make sure you're only focusing on the behaviors that are most concerning at the time. So decide ahead of time, all right, we're going to work specifically on staying seated, or we're going to work on staying seated and not throwing things. But we're not going to worry about kind of making vocalizations, for example. That's for later. We just want them to stay in the seat and not throw things. That would be the real success. Kind of the other stuff, just deal with it. Kind of don't worry too much about those other behaviors. If they occur, they may be annoying, they may be embarrassing, but we're going to let that stuff slide. Then stick to it. Don't be making stuff up in the middle of the experience, right? As you're out in the restaurant, now you have a whole new situation, and kids are good at this. They always find the thing that you weren't expecting, so you have to adapt, but really do your best to follow through on what you've said, and then use this function-based strategy like I talked about. Don't overstay. We said we were only going to order appetizers so we could be there for a half hour and then go. But again, hey, it's going so well. Let's, get the seafood tower that you have to order a day ahead or whatever. And you end up finding out that now things go badly. And if you leave suddenly, then the individual learns that that's a good way to get out of a situation that they don't like. Behavior management strategies. I talked about this earlier. These are the things that you do to kind of minimize the impact or the effect of the behavior. So a good example of how these can be important is when dealing with behavior like elopement. And so some colleagues and I have done a lot of work on this type of behavior. So wandering away or running away, super dangerous behavior, can have really, really dangerous outcomes. And so behavioral interventions, they're absolutely function-based interventions, right? Kids run away for different reasons. That behavior can serve different functions. Some kids run away because they don't like what's going on over here and you're telling me to do work, I'm out, right? And other kids run away because there's the candy aisle over there and I want to go over there. Or, we had a child who had moved houses and would sneak out in the middle of the night and walk 1.5 miles in the dark to get to their old home. So these are all different purposes. And so there's different interventions that one can implement. But in the meantime, it's really important to have these management strategies to address elopement should it occur or should an attempt occur. Things like having deadbolts on the lock. Things like teaching safety skills so that if this individual has any kind of verbal skills so they can at least tell people their name or their name and address if they do get lost. Teaching them about or identifying what is the procedure in your community for notifying first responders that someone's gone missing so you can have people come out and look. talk to your neighbors and ask, if you see our kid out wandering alone, they're not supposed to do that. It's okay. Please stop them. And here's my number. And you can call me if that happens. These are the kinds of things that can be done to just mitigate the effects of the behavior if it happens while you're working on that intervention approach. Here's an example of some things that we do in our unit to mitigate the effects of behavior. These are protective gear that our staff wear in order to work with really aggressive and destructive kids that we see on our service sometimes. Here's just some other examples that are maybe not so intimidating. I like to point out that this is me modeling some sleeves that we sometimes wear. I look just like that, I swear. But this was something that we did with the folks in the emergency department at the children's hospital where we work, so that when folks came in with behavioral crises, they were able to wear these sleeves under their long sleeve shirts and work with kids in ways that would otherwise be that they were sometimes intimidated, and that would come across the individual, right? So someone would come in to do a blood pressure check, and the kid didn't like that. It was a freaky feeling, and so they would get aggressive and thrash around. Well, if the staff were too scared or they would act intimidated, the kid picks up on those cues and those signals, and all right, I got your number and I know that I can freak you out just by flailing around a little bit, and then you'll back off, right? I don't have to have my blood pressure taken. Staff learned that if they could wear some of this protective gear, they weren't so nervous. They knew that if somebody hit them, it's not going to solve all of the problem, but it's not going to cause a real injury as a result. And so they were able to work more confidently with these kids and therefore do their work, and the kids were able to stay more calm. And so again, examples of how protective equipment can be important. And then lastly, I talked about crisis management, which really is doing just whatever it takes to end a crisis as quickly as possible. Now, this is important, and it's an important tool to have in the toolbox, but it's important to also acknowledge that oftentimes the best way to get a crisis to end quickly is the exact opposite of the thing that is being done as part of an intervention. And because those interventions, the purpose of those is to over time reduce the behavior and see a reduction, that the behavior will decrease over time. Well, that means that by intervening in this way, you actually might see things going, and then you see things get worse again because you're doing whatever it takes to end the behavior. Let me just give you an example. There was a young man that we were working with, and we knew that he really liked going out trips to the public. And what he really liked to do is to go buy a snack at the local grocery store. We took him to the grocery store. We're walking in the parking area, and he's a big guy, and he dropped to the ground. Now it was just me and one other person, and he's big, right? I'm talking like several hundred pounds. Can't lift him by ourselves. We're in the parking lot right out front. There's cars going by. This is not the time to wait him out, right? He's going to get struck by a car if we're not careful. So rather than just do the behavioral intervention, which we knew over time would work, which is sitting on the ground doesn't get you what you want, it was instead, hey, quick, run inside, get the Snickers bar, come out, stand on the sidewalk and wave it at him. Hopefully he'll get up and move, and that did happen, and he was able to get out of that dangerous situation as quickly as possible. But what did he learn, right? From a functional standpoint, he learned dropping to the ground, got me a Snickers bar. That was pretty great. And so that meant that from then on, we had to have a strategy. So it was important to do that, even though, again, from a long-term standpoint, things might have gotten worse instead of better. But if the situation had gone tragically, there is no next time. So we had to use that crisis management strategy. But it also means that we have to acknowledge that when we did that, we may have made things a little bit worse, which means that from our standpoint, when we train other folks on crisis management strategies, we actually tell them you only get to call it a crisis one time. After that, you know that this is a tool in their toolbox that they'll pull out at random times, and you got to have a plan for how you're going to deal with it. In his case, it meant we didn't go to the store next time until we had 4 people, so that if he dropped to the ground, we really could lift him, and he couldn't get the Snickers bar unless he engaged in the appropriate behavior instead. And so we had to have a plan. I see this a lot at schools and other places where folks are like, oh no, crisis. It's the 7th crisis this week. It's not a crisis. You should have had a plan in place at that point so that you could deal with it in a proactive way so that it's actually reducing the behavior over time. So I know I talk really, really fast, and I apologize for that. There's a lot that I wanted to get to, and I really tried my best. I also know that I really just scratched the surface on some of these things, and that there are probably lots of other points that could be made. Some of my main take-home points. First, again, problem behavior is actually pretty orderly, even when it seems random. That functional analysis that I showed where you go out in the public and you see a problem, and it seems like, why is this happening here to me today? But when one gets really systematic about how they look at these behaviors, you usually can find a purpose, even if it's not apparent just on the face of it. And that, I think, is something that's really important, because as a caregiver, it does feel random sometimes. I don't understand why this is happening to him, and therefore maybe even to me. And so knowing that there is a purpose for these behaviors for the most part, and if we can understand that purpose, we can come up with strategies to deal with it, hopefully gives people a little bit of peace of mind. Secondly, working on these behaviors takes work, and it takes consistency, and it really requires understanding what the purpose of the behavior is, or its function for that individual. And then thirdly, if the kids' behavior is going to change, the people who are setting up the world around them have to change what they're doing about it. So that does mean that there's effort involved on the part of those who care for these individuals, which is difficult. And I acknowledge that and I recognize that. It's a big part of what we try to do is in our center is to try to understand how we're going to do that and to work with families so that what we're not asking is too impossible for them. So I'm ending now, and I don't know if we have time left over for questions. I hope that we do have a little bit of time. If we do, one of the things I always want to tell folks is I'm very eager to share any information that I have or that I can share, but at the same time, it's really difficult sometimes to do exactly what I think a lot of people probably want most, which is help solve my problem. And so that is difficult when I haven't, there's a reason why in the clinical work that I do, these types of interventions take weeks and weeks and weeks. And so to just kind of on a spur of the moment, give you a perfect advice that's going to make everything better for you is really difficult. And I apologize for that. It's actually part of why the ethics code for the organization I belong to says I'm not supposed to do that, but I will do my best to answer any questions if we have time. And I'll